From Physical Diagnosis PDX, I am Andre Mansour. He is Joseph Nugent. And this is the art and science of the jugular venous pulse.
Let's begin with a quote from prominent heart failure physician Carl Lear, who has written extensively on the importance of physical examination. Dr. Lear writes, quote, "The inability to properly assess the pressure level and wave contour of the internal jugular veins should encourage the cardiologist interested in heart failure to either learn and develop skill in this component of the physical examination or move to another area of cardiovascular medicine." We couldn't agree with this more. In fact, while Dr. Lear was addressing cardiologists, we believe this statement is even more applicable to the general internal medicine clinician. Our approach to evaluating the jugular venous pulse includes three separate but related components. Number one, identification of the jugular venous pulse. Number two, quantitative assessment of the jugular venous pulse. And number three, qualitative assessment of the jugular venous pulse. At the end of the presentation, there will be a multimedia quiz that will test your knowledge. Section 1. Identification of the jugular venous pulse. Identification of the jugular venous pulse is the single most important of the three components. Without it, components 2 and 3 cannot even be attempted. Often you will hear from trainees and colleagues that the jugular venous pulse couldn't be visualized for X or Y reason. Usually it's because of a large neck or the presence of a beard. In our experience, the jugular venous pulse is visible in the vast majority of patients. So where do we find the pulse? The best location for viewing the jugular venous pulse, and the one that you should go to first, is the right internal jugular vein. It is ideal because of its direct route into the right atrium. If the right IJ is unavailable, then the left IJ should be examined next. It's important to note here that we are not actually visualizing the internal jugular vein itself. Instead, we are visualizing the movement of the skin that overlies the vessel. If neither IJ is available, then we can use the external jugular vein. If we have exhausted that list and still cannot find the pulse, perhaps there are other places to look, which we will get into later in the presentation. This data is from a 1973 study that sought to determine whether the jugular veins were a reliable guide to right atrial pressure. The graphs show right atrial pressure plotted on the x-axis, and then from left to right, pressures within the right internal jugular vein, left internal jugular vein, and the external jugular veins are plotted on the y-axis. All measurements were obtained directly. You can see that for the most part, there is a linear relationship between the pressure within the right atrium and the pressures within the jugular veins. This demonstrates two things. First, the right IJ is highly reliable for estimating central venous pressure. Second, the left IJ and the EJ are nearly as reliable as the right IJ. It should be noted that while the EJ can be used to estimate central venous pressure, it doesn't transmit the actual waveform very well, so it is less reliable for the purposes of qualitative assessment. Let's talk about the approach to identifying the jugular venous pulse. The first and most important step is patient positioning. Often, we walk into a room and the patient is slouched in bed with their neck flexed forward. If you try to move the back of the bed up and down to change the patient's angle, only their neck will move, and this will compromise your exam. To address this, what I usually do is flatten the bed and help the patient slide up so that their head is all the way to the top edge of the bed. Now when I adjust the backboard, it will move the angle of the patient's torso and not just their neck. You want the patient's neck and torso to be in the same plane, and you want to make sure that the neck is nice and relaxed. You don't want flexion of the sternocleidomastoid muscles getting in your way. Sometimes you have to add or subtract pillows to accomplish this. Step 2 is to observe the neck. The tendency is to observe the neck from a perpendicular perspective. However, if you do this, you are liable to miss subtle movement. In order to pick up on subtle movement, it is best to assume a tangential vantage point. Step 3 is finding movement in the neck. The traditional window for viewing the jugular venous pulse is confined to the region of the neck between the clavicle and the angle of the jaw. Sometimes you have to change the patient's angle in order to bring the waveform into this window. The final step in this process is to determine whether the movement you are seeing is venous or arterial. There are a host of strategies for determining whether the movement you are seeing is arterial or venous. The waveform itself can be revealing. An arterial pulse has a single peak that is quick and sharp. In contrast, the venous pulse is typically double and undulating in nature. The most striking feature of the arterial pulse is the outward movement. Obviously, what goes out must come back in, but it does so subtly and gradually, and it's hardly noticeable. The most striking feature of the venous pulse, on the other hand, is the inward movement. The arterial pulse tends to be pinpoint, involving a small area of the neck. The venous pulse, on the other hand, is diffuse, often involving a large area of the neck. The arterial pulse does not vary with patient positioning, respiratory cycle, or abdominal pressure, while the venous pulse does. As the angle at which the patient is positioned decreases, the venous pulse climbs up the neck, and as the angle is increased, the venous pulse moves downward. The venous pulse is also affected by respiration, normally moving down with inspiration, and with abdominal pressure, the venous pulse will move up the neck. Finally, the arterial pulse is palpable, while the venous pulse is almost always non-palpable. What is the nature of the pulsation shown in this video? Notice that there is a single outward peak without significant inward movement, and there's one small area in particular that seems to contain most of the movement. It's pinpoint, and you can put your finger right on that spot, and if you did, you would feel a pulse. This is a normal carotid pulse. In this annotated video, you can follow the synchronized cursor along the arterial tracing.
Compare and contrast the arterial pulse with the venous movement shown in this video. Notice that there are two peaks and two troughs, and it is the inward movement that really catches your eye. Notice also that the venous pulse is diffuse, stretching over most of the neck.
The Abdominojugular Reflux test is a physical examination maneuver that is performed by placing firm pressure over the patient's abdomen with the palm of the hand while observing the effect on jugular venous pressure. This test has several applications. First, it can serve to distinguish a venous pulse, which will rise with abdominal pressure, from an arterial pulse, in which there is no change with abdominal pressure. Second, a sustained rise in jugular venous pressure greater than 3 centimeters lasting more than 10 to 15 seconds while abdominal pressure is continuously applied is highly suggestive of elevated wedge pressure greater than 15 millimeters of mercury. In this video, an increase in JVP is clearly demonstrated upon application of abdominal pressure. As we discussed earlier, we typically first attempt to evaluate the jugular venous pulse using the right internal jugular vein. If it's unavailable, we go to the left internal jugular. This video is simply a demonstration of the jugular venous pulse on the left side of the neck. When the right and left internal jugular veins fail to provide adequate evaluation of the jugular venous pulse, the external jugular vein can be used to estimate central venous pressure. The external jugular is easily recognized as a visible vein on the surface of the neck, much like the veins on the dorsum of the hand can be visualized. Unlike the internal jugular vein, which provides indirect evaluation of the jugular venous pulse via movement of the overlying skin, the actual vessel itself is not visualized. The external jugular vein provides direct evaluation of the jugular venous pulse. However, the external jugulars often transmit the venous waveform poorly. These veins are therefore suitable for quantitative assessment of the jugular venous pulse, but are not reliable for qualitative assessment. This video also nicely demonstrates an arterial pulse and venous pulse side by side. You can easily appreciate the differences that distinguish them. The arterial pulse is characterized by a single outward peak that is sharp and quick, and occurring over a relatively small area of the neck. The venous pulse is double, diffuse, and undulating. The traditional window for viewing the jugular venous pulse is confined to the region of the neck between the clavicle and the angle of the jaw. However, when central venous pressure is markedly elevated, the jugular venous pulse may not be readily visible within that window, even with the patient sitting in the upright position. In such circumstances, be sure to look above the jaw, as the pulse is often transmitted by veins at the periauricular area, temple, or forehead. This video demonstrates the unmistakable inward movement of the venous pulse in the patient's temple. Here is another video demonstrating the unmistakable collapsing movement of the venous pulse in the patient's forehead. Section 2. Quantitative Assessment of the Jugular Venous Pulse. Now that we have established how to identify the jugular venous pulse, we are ready to address the second component of the exam, quantitative assessment. This is also known as jugular venous pressure, or JVP. When clinicians report a JVP of 8 centimeters of water or 16 centimeters of water, they are providing a quantitative assessment. This is the most frequently applied component of the exam, used on a day-to-day basis. We should begin by asking the question, what are we measuring? We are measuring right atrial pressure. In order to interpret the significance of the JVP, one must be familiar with normal right atrial pressure. When measured in millimeters of mercury, normal right atrial pressure is less than 6. When measured in centimeters of water, normal is less than 8. So why are we measuring the JVP? First, it can be helpful in establishing a diagnosis. For example, in a patient who presents with dyspnea, the JVP exam is an instrumental part of the workup that at worst can narrow the differential diagnosis, and at best, provide you with a diagnosis. In addition to its diagnostic utility, we often use JVP to establish and follow a patient's volume status. Pressure in the right atrium is usually a function of volume. As volume goes up, so does pressure. So how do we measure JVP? We want to measure the height of the column of blood above the middle of the right atrium. But the right atrium sits in the middle of the chest and we can't see it. So we must use landmarks that we can see to extrapolate to the center of the right atrium. The angle of Louis represents one such landmark. In the supine position up to about 30 degrees, the angle of Louis is about 5 centimeters above the middle of the right atrium. At 30 degrees or more, that number increases to 8 to 10 centimeters. The clavicle is another landmark that we can use, but only in the upright position, where it is 12 to 16 centimeters above the middle of the right atrium. Textbooks teach a method for measuring JVP using a ruler and another straight edge. We don't know of any clinicians who actually use this technique in real life. Instead, measure the width of your hand. Your hand can be used as both the vertical straight edge and a ruler, and you can estimate JVP that way. This video demonstrates a venous waveform near the angle of the jaw with the patient at 30 degrees. The top of the waveform is around 10 centimeters above the angle of Louis. If we assume the angle of Louis is 8 centimeters above the middle of the right atrium, then the JVP here is 18 centimeters of water. When you see abnormal indentations in a patient's forehead, you should immediately consider long-standing elevated central venous pressure. This patient serves as a nice example. Here is the same patient in a more reclined position, and you can see that those veins have now engorged with blood, indicative of elevated central venous pressure. We have found that the dorsum of the hand can provide fertile ground for estimating central venous pressure. When the internal or external jugular veins are unavailable, or when the pressure is extremely elevated, try using the hand veins to estimate central venous pressure. When the hands are at the patient's side, check for engorgement of the veins. If present, lift the hand high above the patient's chest until the veins drain and flatten. Then, slowly lower the hands down to find the moment that the veins begin to fill. The distance between the top of the hand at that moment and the angle of Louis can be used to estimate central venous pressure by adding it to the estimated distance between the angle of Louis and the center of the right atrium. This technique may also be useful in the setting of severe tricuspid regurgitation, when the average central venous pressure can be difficult to estimate using the veins of the neck. Section 3. Qualitative Assessment of the Jugular Venous Pulse. Now that we have discussed the first two components of the jugular venous pulse examination, identification and quantitative assessment, we are now ready to move into the third and slightly more sophisticated component, qualitative assessment. Evaluation of the jugular venous waveform can provide a host of useful information about the heart, beyond simply measuring right atrial pressure. To illustrate this point, ask yourself how you define Mobitz 1 heart block. Most would define this condition as periodically dropped QRS complexes on an electrocardiogram that are preceded by progressively lengthening PR intervals. When did Wenckebach describe Mobitz 1 heart block? It was the year 1893. When was the electrocardiogram first used in patients? 1895. So how is this possible? How did Wenckebach describe Mobitz 1 before the electrocardiogram was available to him? Wenckebach used the jugular venous waveform to describe the heart block that now bears his name. The way he did it will become clear as we proceed in this presentation. To be able to perform a qualitative assessment of the jugular venous pulse, one must be able to understand the normal waveform and the cardiac events that cause each of its components to occur. It's helpful to orient yourself to the cardiac cycle. Let's start with the first peak in the waveform, the A wave, which is caused by right atrial contraction. When the atrium contracts, pressure inside the atrium increases, and this is seen as a positive deflection in the jugular venous waveform. Atrial contraction occurs at the very end of diastole, when the atrium is trying to push the last bit of blood into the right ventricle. Next, during early systole, isovolumetric ventricular contraction triggers closure of the tricuspid valve, producing the C wave. In mid-systole, a combination of atrial relaxation and descent of the atrial fluid during ventricular contraction results in the X descent. The third peak, the V wave, occurs as a result of atrial filling during late systole. Finally, passive ventricular filling in early diastole produces the Y descent.
Recall this video from earlier in the presentation. The first step is identifying that the movement here is venous, but now we want to move beyond that to perform a qualitative assessment. In the annotated video shown, you can follow the cursor along the venous tracing to identify each component of the waveform in the neck. Remember that the C wave is not visible at the bedside.
This is another example of a normal jugular venous waveform that perhaps demonstrates the individual parts of the waveform a bit more clearly. Every aspect of the cardiovascular examination should be performed together when possible. We often look at the jugular venous pulse while simultaneously auscultating the heart or palpating the peripheral pulse. This allows the examiner to establish the cardiac cycle and understand whether events are occurring in systole or diastole. One can identify components of the jugular venous waveform by simultaneously auscultating the heart. We know that the C wave occurs in the middle of the X descent, and the C wave occurs as a result of tricuspid valve closure, which is the same event that produces S1. So the X descent should occur at the same time as S1. S2 occurs on the upstroke of the V wave. What is the timing of the S4 gallop? It is a late diastolic event coinciding with atrial contraction, which of course produces the A wave. When does the S3 gallop occur? It is an early diastolic event coinciding with passive ventricular filling, which of course produces the Y descent. The venous waveform in this video is characterized by one dominant descent. Is it the X descent or the Y descent? And how could you tell? Well, as just discussed, you could auscultate the heart simultaneously, because of course S1 should coincide with the X descent. Or in this case, you happen to have a visible arterial pulse that can serve as a nice frame of reference. The arterial pulse should occur, of course, during the X descent. If you time it, you will see that the arterial pulse in this video occurs at the same time as the dominant descent in the venous waveform, indicating that it is indeed the X descent. Now that we can recognize the normal jugular venous waveform and the cardiac events that cause each of its components, we are ready to discuss various abnormalities. What is the abnormality in this tracing? There is no A wave, a very small X descent, and remember that normally the X descent is more prominent than the Y. And the waveform is occurring in an irregular rhythm. These are all features of atrial fibrillation. Because atrial fibrillation does not allow for coordinated atrial contraction, the A wave disappears. Similarly, since there is no atrial relaxation in the setting of atrial fibrillation, the X descent is smaller than normal. What is the abnormality in this tracing? The A wave is more pronounced than usual. These are giant A waves. As we now know, the A wave occurs as a result of right atrial contraction. When there is resistance to right ventricular filling, right atrial contraction generates increased pressure, resulting in larger than normal A waves. Giant A waves occur with every beat, unlike cannon A waves, which usually occur intermittently. Causes of giant A waves include tricuspid stenosis and increased right ventricular end diastolic pressure from any cause, for example, pulmonary hypertension. Listen for an associated right-sided S4 gallop. What is the abnormality in this tracing? The A wave is even more pronounced compared to the giant A wave, and it occurs intermittently between normal waveforms. These are cannon A waves. Cannon A waves usually occur intermittently, unlike giant A waves, which occur with every beat. The cannon A wave is generated when the right atrium contracts against a closed tricuspid valve, which occurs sporadically as a result of atrioventricular dissociation. What is the abnormality in this tracing? The X descent has been replaced by a large CV fusion wave. This is known as Lancisi sign and is a physical finding of tricuspid regurgitation. In the setting of severe tricuspid regurgitation, retrograde blood flow into the right atrium during ventricular systole results in loss of the X descent, creating a fused CV wave that appears as a large pulsation within the internal jugular vein. This wave is typically followed by an augmented Y descent, a consequence of an increased pressure gradient between the right atrium and right ventricle. The often palpable CV fusion wave is one of the exceptions to the rule that the jugular venous pulse is non-palpable. Listen for an associated holosystolic murmur over the left lower sternal border that augments with inspiration. What is the abnormality in this tracing? The Y descent is sharper and deeper than usual. This is known as Friedreich sign and is a physical finding of elevated right atrial pressure occurring as a result of conditions such as constrictive pericarditis and restrictive cardiomyopathy. The Y descent occurs as a result of passive ventricular filling during early diastole. In constrictive pericarditis, for example, the characteristic sharp and deep Y descent reflects rapid filling in early diastole, which occurs when the unyielding pericardium elevates atrial pressure and limits ventricular filling to the early diastolic period. Listen for an associated pericardial knock. What is the abnormality in this tracing? Here we have sharp X and Y descents, known as the W sign. In around 1/3 of patients with constrictive pericarditis, the prominent Y descent occurs in combination with a prominent X descent, creating two steep troughs known as the W sign. As before, listen for an associated pericardial knock. What is the abnormality in this tracing? Here, the jugular venous pressure paradoxically increases with inspiration. This is known as Kussmaul sign. Decreased intrathoracic pressure during inspiration normally leads to an increase in venous return to the right side of the heart, with an associated decrease in jugular venous pressure. When there is impaired filling of the right ventricle for any reason, the jugular veins instead become engorged. Causes of Kussmaul sign include right ventricular infarction, severe right ventricular failure, restrictive cardiomyopathy, constrictive pericarditis, and tricuspid stenosis. All right, we are ready for the last section of this presentation, quiz mode. Here you will be quizzed on the various qualitative abnormalities of the jugular venous pulse that you just learned about. Each video you will see illustrates a qualitative abnormality. The video will repeat in a loop. Watch the video a few times until you get a sense of the movement in the neck, and then try to determine what the qualitative abnormality is. Then, the video will play in slow motion and will be annotated so you can better appreciate the abnormality. Here is the first video in the quiz. Take a few moments to watch the video on your own. Now study the annotated video. Demonstrated in the video is a single dominant peak and a single dominant trough. This is Lancisi's sign of tricuspid regurgitation. You might also expect to hear a holosystolic murmur at the left lower sternal border that augments with inspiration and that occurs at the same time as a CV fusion wave. This patient had severe tricuspid regurgitation related to dilated cardiomyopathy. Here is the next video. Take a few moments to watch. Now study the annotated video. Demonstrated in the video is a paradoxical rise in jugular venous pressure with inspiration, known as Kussmaul sign. Remember that normally the JVP should decrease with inspiration. You might also note the sharp and deep X and Y descents, known as the W sign, which is highly specific for constrictive pericarditis. This patient developed constrictive pericarditis many years after orthotopic heart transplantation, a rare sequela of that procedure. Here is the next video. Take a few moments to watch. Now study the annotated video. Demonstrated in the video is a sharp and deep Y descent, known as Friedreich sign, which is often seen in patients with constrictive pericarditis or restrictive cardiomyopathy. Remember that the normal jugular venous waveform is characterized by an X descent that is more dominant than the Y. This patient developed transient constrictive pericarditis following an admission for a bloody pericardial effusion of unknown etiology. Here is the next video. Take a few moments to watch. Now study the annotated video. Demonstrated in the video is a giant A wave, which can be seen in conditions in which there is resistance to right ventricular filling. This patient developed severe pulmonary hypertension related to methamphetamine use. Here is the next video. Take a few moments to watch. Now study the annotated video. This is another demonstration of Kussmaul sign. You may also notice the radiation tattoo marker in the middle of the patient's chest. This patient developed constrictive pericarditis many years after radiation therapy for mediastinal lymphoma. Here is the next video. Take a few moments to watch. Now study the annotated video. This is another demonstration of Lancisi's sign. This patient developed severe tricuspid regurgitation related to catheter-induced injury during a right cardiac catheterization procedure. Here is the next video. Take a few moments to watch. Now study the annotated video. Demonstrated in the video is an exaggerated normal response to respiration, where the jugular venous pressure rises during expiration and lowers during inspiration. Such exaggerated respiratory variation is indicative of underlying lung disease. This patient had severe COPD. Here is the next video. Take a few moments to watch. Now study the annotated video. Demonstrated in the video is an irregular rhythm with the absence of an A wave and a small X descent, indicative of atrial fibrillation. Here is the next video. Take a few moments to watch. This is another demonstration of Kussmaul sign. Here is the next video. Take a few moments to watch. Now study the annotated video. This is another demonstration of Lancisi's sign. Here is the next video. Take a few moments to watch. Now study the annotated video. This is another demonstration of giant A waves. This patient had severe tricuspid stenosis. Here is the next video. Take a few moments to watch. This is another demonstration of Kussmaul sign. Here is the next video. Take a few moments to watch. Now study the annotated video. Demonstrated in the video is an intermittent Canon A wave indicative of atrioventricular dissociation. This patient had complete heart block.
Final quiz question. This clip depicts clear movement in the neck of the character Maximus from the movie Gladiator, who, by the way, is supposed to be dead at this point. Do you think the movement in the neck is arterial or venous?
The pulsation we are seeing is clearly venous based on the large area of neck involved and the dominant inward movement.
So let's return to Wenckebach. How did he describe Mobitz 1 heart block without the benefit of an EKG? As you might have already imagined, he used the venous pulse. We know Mobitz 1 as PR prolongation leading up to a dropped QRS complex. So what's the equivalent of the P and R waves in the jugular venous waveform? The P wave on the EKG represents atrial depolarization, or contraction, and the R wave represents ventricular depolarization, or contraction. Respectively, these events cause the A wave and the X descent in the jugular venous pulse. So Wenckebach recognized AX prolongation leading up to dropped arterial pulses. Alright, that's it. Please use the comment section to let us know what you think of this presentation and if there are ways that it can be improved.
These are the references that we use for this presentation.